All right, good morning, everyone. To be respectful of everyone's time, we'll go ahead and get started. Thank you so much for joining us today for the third in a series of Revenue Cycle Improvement webinars with BKD. My name is Shannon Norman with the National Rural Health Resource Center. Today's webinar will be recorded and the playback will be made available on our website along with the slides from today's presentation. After all of the Revenue Cycle Improvement webinars are complete, we will email out links to all of the hospitals. Today's topic is telehealth, getting started with proper coding and billing of telehealth services. Our presenter today is Marla Dum, Managing Consultant with BKD. But before turning it over to Marla, we have two quick poll questions. Cineva, would you mind pulling up the polls for us? We'll give everybody just about a minute or so to respond to these two. All right. Thanks, everyone, for participating in the poll. If anyone has any questions during the webinar, please feel free to type them into the chat box on the left-hand side of the screen. Otherwise, there will be an opportunity to ask your questions at the end of the call. Everyone's line is muted, so if you do have questions, you'll just need to press *2 to unmute your phone line. So, Marla, I'll turn it over to you to get started with the presentation.
Wonderful. Thank you, Shannon. Good morning. We are going to be talking about telehealth today, and we are excited about discussing some of the updates to these services and some of the things that are coming down the road as far as legislation, particularly for our rural health clinics. And so a lot of that information we will have in the presentation for you today. We're really going to provide an overview of telehealth. It seems kind of cut and dried because there are just a few codes that are used for some of the services, as well as a defined list of services that can be used for telehealth. So we're going to go through all of those today. We're going to talk a little bit about some of the background, some of the definitions that we have when we're discussing telehealth or telemedicine, eligible locations where that service can be provided, eligible providers, in other words, who can provide, not only serve as an originating site, but also who can provide the actual professional service, who are eligible. Eligible services themselves, and then billing and reimbursement. We'll talk a little bit about that, and then run through a scenario at the end of the presentation just to give you an idea, particularly from the originating site and distant site scenario. We've already also provided you some references as well that may be helpful to you. As far as background, telemedicine really has taken a surge over the last 5 to 10 years. It started out very small. It started out primarily in the hospital setting, quite frankly. Some of the telemedicine types of services, or these remote visualization services, were really started in the intensive care units, where some of the hospitals would set up remote monitoring stations remotely, where they were viewing the patients, having those conversations with providers via telecommunication. And so it really started out on the hospital side. Obviously, patients in rural areas, we do see that they have a higher rate of some of our more unhealthy behaviors, but also the biggest driver is because those health-related issues are in part driven because they have less access to health care. Often those areas will have less access to healthy food, or maybe it is in a poverty-stricken area where they just are not able to seek medical care when needed. And so they really saw that not only could this be used on the hospital side, but really universally in healthcare. And so it has just incrementally expanded over the last several years, and now is a huge driving force in the rural communities to bring those specialized and primary care health services to the rural areas. They also have statistics that show under the CDC that rural residents have an increased likelihood of premature death, and usually this is because the 5 really chronic illnesses are leading causes of that death, which includes heart disease, cancer, and unintentional injury that may not be able to be treated right away, chronic lower respiratory disease, and stroke. So delivery of healthcare via our telehealth technology really brings quite a few benefits to the population. To improve the health of those rural residents where they do have access, particularly on a specialty perspective, when they may have primary care providers in their area, but this gives them the opportunity to be able to be in their PCP's office, but then call out to a specialist in an urban area, for example, where they will receive that care that they otherwise may not be able to travel that far. They may not have access to that in their community. It reduces those barriers, quite frankly. It reduces that barrier of not being able to go into a specialist's office. It takes care of transportation problems, eliminates the approach or improves the approach to communication and counseling for their illnesses. The monitoring of chronic conditions can be much more efficient, and delivers healthcare quickly in emergency situations as well, which we are seeing in the last year where they've increased use of the acute stroke assessments are now eligible for use through telehealth, which a lot of organizations are now using. So why do we focus on the coding and billing of telehealth? As with any service, we always want to make sure that our billing correctly reflects where that service has been rendered, and that always has a trickle-down effect when we're looking at what is the service, who is providing the service, and where is it being rendered. That really ties to not only revenue codes on the facility side, but place of service codes on the professional side. Are we receiving the correct reimbursement from the correct bucket from our payer, whether it's a clinic or a hospital professional service? Are they eligible services to begin with? So that's why we're paying attention to a lot of different elements when we're looking at the coding and billing of telehealth. So we are looking at site of service. What are those criteria? We are also needing to look at what are the service codes that we can perform as defined by CMS. CMS has the list on their website that is the eligible codes that are felt to be appropriately rendered through telecommunications. It's not every professional service. In great degree, it's a lot of our evaluation and management services. It's a lot of our behavioral health services like therapy that can be done where you're looking at the patient through telecommunications, but there are some services obviously that require hands-on, require the patient to be directly in front of the provider, and so those types of service codes are not included. So those are things to look at when you're setting up these programs. We're looking at the correctness of the type of bill, particularly if we're billing from a facility perspective. Perhaps the patient is housed at the hospital, so we're making sure that our type of bill is correct for the setting, that our place of service codes is appropriate on the 1500 claim form if used, and or our revenue codes are correct if a UB04 claim form is sent through. That will make sure that that claims process is smooth and that it won't hit against any edits with our payers. We also want to make sure that we receive reimbursement correctly so that we are using the correct service codes, as well as are there modifiers we need to append? Are there other things we need to take into consideration on that claim form to make sure that the service goes through cleanly and is reimbursed correctly? And then also telehealth is just something that is monitored, and increasingly so by a lot of our governmental agencies. Even recently, there have been some reports coming out, particularly from the OIG, where they have been doing some deep dives into telemedicine, where they have found entities that have billed inappropriately, showing a service was rendered as telehealth when it was not actually rendered as such, or billing for services that are not eligible for telehealth services. So telehealth in general is on the radar of our recovery auditors, our RACs, the Medicare administrative contractors themselves, and obviously the Office of Inspector General. For example, the Office's Inspector General released this report for CMS paid practitioners for telehealth services that did not meet Medicare requirements, and this was issued just in the last year. The distant site service was billed, and the distant site service is where the professional provider is located. That service had been billed without a corresponding originating site service. So they could not show that there was a correlation with the patient being on the other end of the line. They could only see charges for the professional service, and you obviously have to have that one-to-one match. Obviously, it may be a completely different organization, but the payer would be going back through to see that we have a match. We have an originating site charge. We have a professional charge as well. And OIG indicated that for this organization, they had a lot of professional charges going through with no indication that a patient was on the other end. They also found that there were unallowable services being rendered in a non-rural setting. And we will touch on that in the next slide or two, where we do have very strict criteria about when and where you can provide telehealth. It is not a universal service that can be provided regardless. It does have to be in a designated rural area. So they also identified that as an issue. Unauthorized originating sites, again, that's where the patient is located, and so that patient does have to be located in a rural or HIPSA site. They also found that there were some non-covered services that were being done through telemedicine and recommended back to CMS that they conduct periodic post-payment reviews, that they implement or clean up their own claim edits to catch some of these issues, and then offer education and training to the organizations that they were looking into. So it is definitely on the radar of our governmental agencies. So the first definition that we're going to talk about is originating site. Originating site is basically, where is my patient? Where's the patient? Where are they sitting when that service is rendered? That is what the originating site is. It must be located in a county outside of a metropolitan statistical area, or an MSA, and a rural health professional shortage area. It must be in a HIPSA. So it's either going to be a county, an MSA, and it's going to be in a HIPSA area. And in order to determine whether or not the site where that patient is located meets criteria, HRSA does have a very helpful tool, and the link is provided for you here, that you can enter the address or the zip code, the county. You can enter that data, and it will automatically pull up whether that site is meeting those rural classifications. If that tool says no, that means that you cannot provide telehealth services for that patient, because it is determined by where the patient is located, not where the distant site provider is located. Now, you might qualify if your site is actually in an area that is participating in a federal telemedicine demonstration project, but again, that would be determined by Medicare, and you would have to be part of that demonstration project, and that would cause you to have an exclusion for some of these shortage areas if indeed you were part of that demonstration project. Otherwise, that is the first rule of thumb that we look at when we're determining, can you provide telehealth to begin with. Authorized sites include a number of areas, and really it's pretty much all of our services. You know, all of our sites of service are eligible for housing that patient if indeed those sites meet that rural classification. So it could be in a clinic, could be in a hospital, PPS hospital, could be a critical access hospital. We also have our RHCs, or our FQHCs, our federally qualified health centers. Those are also eligible sites. Dialysis centers, nursing facilities, community mental health centers, renal dialysis facilities, homes of beneficiaries with ESRD who are receiving dialysis, and you would note that that is a very distinct definition of that site, where that patient would have to have that documented condition also being on dialysis in order for the home to actually be eligible. Otherwise, the patient's home is not acceptable. We have received a lot of questions over that over the last couple of years about whether we can have the patient at home and have them call in, and the actual home is not an eligible site. And then also the mobile stroke units, which were added last year as an eligible site, in part because they now have that professional assessment of acute stroke that is eligible regardless of where that patient is assessed. You will note at the bottom of the slide also we did want to provide you with some of the references about why they added those mobile strokes. And again, that was part of the Bipartisan Budget Act of 2018, where they kind of removed location restrictions if in fact that telecommunication was done to perform that assessment of acute stroke. They definitely did not want to have any restrictions on that particular service. Otherwise, those other sites are eligible if they are in a rural area. They also removed the restrictions on professional services or distant site services for opioid use disorders or substance use disorders. They wanted to make sure that this promotion of assistance for these patients was really across the board, that would be a more open eligibility area. So in July of 2019, the SUPPORT Act, or the Substance Use Disorder Prevention that promotes opioid recovery and treatment, the SUPPORT Act for patients and communities, did remove any geographic restrictions on the originating site. So in other words, if you had the patient located in a site, excuse me, if the patient was located in a site that ordinarily would not have met those MSA or the HPSA requirements, then that would be okay if indeed the telecommunication service was for one of these OUD or SUD treatment services. For these same conditions, they did add the patient home as an eligible site. So that would be two scenarios where that would be appropriate to have the patient at their home calling into their provider for assistance for an OUD or SUD treatment service. That would also be appropriate if the patient was being assessed for stroke. This was done in part to enhance that treatment efficiency for substance use disorders and or the related mental health disorders that often will coincide with that substance abuse. So that is one of the exceptions to where an originating site can be. The second thing we have is distant site. So we have the originating site, which is where the patient is located, and all the criteria that need to be met to make sure that it is in an eligible rural location, with the two exceptions of the stroke assessment and the substance abuse or opioid abuse treatment. Then we have the distant site. This is where your professional staff is located. The professional staff is the one who will be communicating with the patient via telecommunications, and we have a list of the eligible providers listed here. Obviously, our physicians, our non-physician practitioners, to include nurse midwives, as well as clinical nurse specialists. Also, CRNAs were added in the last few years as acceptable. There are occasions when a CRNA will be the treating provider, particularly if a patient is in some type of a pain program. So they were added in the last year or two. We also have our behavioral health staff, clinical psychologists and clinical social workers, with the exception that they are not billing for that diagnostic interview exam with medical services, because obviously they would not be providing those medical services, or medical evaluation and management services. They are only to be doing therapy services, in short, by telemedicine. So there is that caveat. As well as registered dietitians or a nutrition professional, as long as all of their licensure, certification, scope of practice are met. They have also been added to the list of eligible providers. Now, the exclusion, which speaks a bit to the question that we had at the beginning of the presentation. At this point in time, rural health clinics and FQHC sites may not provide distant site services. In other words, one of your professional staff who are currently in the RHC may not have a telecommunication coming into the RHC where that RHC professional staff renders that professional service. We do run into this situation a lot with rural health clinics as well as FQHCs, greatly in part to behavioral health. That is usually what's driving that request because they have patients in rural areas who are calling in for behavioral health assistance. Right now, the RHCs and the FQHCs for Medicare may not render that distant site service. Now, there has been multiple pieces of legislation that have gone to Congress over the last 10 years in the attempt to add this to an eligible service for RHCs and FQHCs. For numerous other reasons, this has never really moved. Once the bill is entered, it often sits in committee. Often it doesn't even move out of committee. I think the last one was in, the 2013 to 2016 time frame, and it literally sat on someone's desk once it had been introduced. The most recent one was introduced in 2019 as part of the Rural Health Clinics Modernization Act, which has multiple things included, but one of those items is in Section 5 of that legislation, which would be to allow rural health clinics to be the distant site for a telehealth visit. So we are crossing our fingers that this legislation will be moved on and will go into place. For whatever reason, Medicare has been unwilling to just go ahead and add that as an allowance under the rural health benefit policy. It is in great part because our benefits that are paid, our encounter rates or our PPS rates that are paid for an RHC or FQHC professional service are face-to-face. That's the definition of the benefit, is that those services must be provided face-to-face. In other words, the patient is in front of that core provider, physically in front of the core provider. And in part, that's why this has not been added just as part of the benefit policy updates, because that patient is literally not standing in front of the provider. That's one of the big reasons why it's not been added. So we will cross our fingers that this final or hopefully final piece of legislation will move, but wanted to provide you with that update. It is on the Hill, but they have a lot going on and it has not been moved forward yet. This is a very small picture. I just wanted to give you a feel of what you would find for approved telehealth services. The site is provided for you. You can click on that and it brings up the Medicare webpage for telehealth services. This list of CPT or HCPCS codes are the only ones that would be rendered and billed to Medicare, or other payers also follow this same type of list of approved services. A lot of them are evaluation and management services, both on the medical side. There are behavioral health service codes. There are inpatient codes. For example, some of our subsequent days can be billed by telehealth. Usually the hospital admission and discharge must be done face-to-face, but our subsequent services may often be done with telehealth. There are also consultation codes you would want to note. There are often specific to the emergency room setting, for example. So I would recommend that you do go out and look at this list of codes to see what is eligible for use in the particular scenario that you do have. I didn't want to go into a number of slides with all of them, but did want to provide you with a link for those codes. That list of codes is reviewed and updated usually once a year at the time that the final rule is dropped. And those codes are usually housed in the Medicare Physician Fee Schedule final rule, although often it will also be included in the OPPS or the outpatient hospital final rule as well. So those are usually addressed at least once a year. So from a billing perspective, what are we looking at? For the originating site, which is again where the patient is located, in some circumstances you will have a 1500 claim form. Let's say it's just a regular outpatient clinic setting. They would be filing to Medicare on a 1500 claim form. The HCPCS code Q3014 is universally used to reflect that we are billing for the originating site. We have the patient here. We are calling out to another provider. So this is basically considered a technical service. It is paid usually based on the facility fee schedule or facility site allowance, and we would report that with 11 place of service if you were in the office setting. It is paid under the physician fee schedule, and for Medicare in calendar year 2020, the allowance is $26.65. So you would receive 80% of that, 20% would be considered part of either coinsurance or deductible. Now in the rural health clinic, for example, if you are housing the patient, which again the RHC may serve as the originating site where the patient is located, then this would be generated on your usual RHC UB04 claim form to Medicare. This would be the same for an independent RHC as well as a provider-based RHC. This is still considered to be a clinic service and would not be considered something that the hospital would drop on their claim form, particularly in a provider-based setting. This would all be considered part of what goes out on the RHC claim under the RHC numbers. Bill type 711, revenue code 780 is used. Q3014 is the HCPCS code reported along with your charge. Now this can be reported at the same time as any other service. So for example, that patient may have also seen another provider within the RHC, let's say for their medical visit for a cold or an upper respiratory infection. And then they are also going to have a telehealth service with a cardiologist who is in another town. So you would also be reporting your medical services for the primary care visit. And then on the same claim, you would also list the Q3014 to say we also are calling out today for a specialist visit. We are housing the patient here. That Q3014 goes through on a separate line item, and you are paid under fee schedule for that particular code. You are then paid your rate for the medical visit that occurred on the same day. Again, the reimbursement would be the same. Medicare has set this facility type of service reimbursement universally. There's no geographic adjustment for the payment for this Q code. So regardless of whether it's performed in Missouri or performed in California, that originating site is paid the same fee. Again, you would receive 80% of that. If you had a hospital setting, or for example, if you were sending this originating site service out from a dialysis center, any type of a facility, that's usually going to go out on a UB04. So these are just some examples for a PPS hospital or critical access hospital. You would send that out on a type of Bill 12 for an inpatient, for example, using the date of discharge as the date of service for that Q code line item. For the hospital inpatient setting, this is a service that is paid outside of the DRG. You're always going to receive just that rate to provide that service. If you're billing outside of a dialysis center, again, you would use the same Q code, usually type of bill 72 and revenue code 78. Usually 780 is the revenue code. This would also be listed on a separate line, and for a dialysis center, this is also paid outside of that per diem rate that a dialysis center facility would receive. For the distance site services, and again, this is your professional services, most of these will go through on a 1500 claim form. This is where your provider or the provider is located at the time of service. So are they in their office when they are having this telecommunications visit? Are they in the hospital? Are they in a nursing facility? Where are they physically located when that service is rendered. So you would report the appropriate, regardless of where they are located, that 1500 claim form would be the appropriate form to submit for Part B billing or your commercial or MCO type of billing, Medicaid to be included. The appropriate CPT or HCPCS code would be rendered and billed, and that would be, again, based on what that eligible code list is from the Medicare website. You would universally report that 02 place of service on the 1500 claim form. This place of service was put into place 2 years ago, I believe in 2018. They put this place of service into action, and so we report the 02 place of service on our claim forms. And so it does indicate to the payer that if they see a 02 place of service for telehealth, that certifies that that provider is certifying that the patient is present on the other end. That is one of the reasons why OIG stepped up its audit focus on this particular service, because of the implementation of place of service 02. They wanted to be sure to follow up after that went into effect, and part of their assessment, as we found, was that the patient was not always on the other end. So that's what the provider is basically telling the payer. I know that I have a patient on the other end. That's who I'm communicating with. For ESRD patients or renal failure patients, that place of service 02 also certifies that at least one visit per month with that ESRD patient was performed face-to-face, that we are not providing all of those required dialysis management visits remotely or by telemedicine, that those at least once per month is face-to-face and hands-on examination has taken place of that vascular access site. That is one of the criteria if you would indeed be generating those services for an ESRD patient and or from an ESRD dialysis center. Again, these professional services are paid under the Medicare physician fee schedule or would be paid under the fee schedule of the payer that you're submitting to. Now, if there are circumstances where that professional service is really performed in a critical access hospital outpatient setting and your critical access hospital has elected method 2 billing, then that distance site professional service could be one that you include as part of that method 2 billing. So that would go out on the outpatient hospital UB04. This is for providers who would have reassigned their benefits to that critical access hospital. They've been submitted to Medicare to indicate that we are part of this method 2 election. And so the line items would be added to that hospital outpatient UB04. The appropriate CPT or HCPCS code would be submitted, and this is one of the scenarios where you would also want to append modifier GT to the service code. GT modifier used to be universally required on all telehealth professional services. When they began implementing place of service 02, they removed the requirement, particularly for Medicare, of needing that GT modifier. They kind of flipped the requirements. Instead of this modifier, we now have this place of service that is telling us that this is a professional service rendered through telecommunication, and so we don't really need that GT anymore. They do have some exceptions to the rule, as is always the case, and critical access hospital method 2 billing is one of those. So if you have someone calling into your staff, they are located in the outpatient hospital setting, and it is a critical access hospital who has elected method 2, and this is a provider that is part of that election, then you would submit the UB04 claim form under the hospital's provider numbers, billing numbers, with the appropriate CPT or HCPCS code for the service rendered. Modifier GT would be appended, and then the revenue code would be the appropriate professional revenue code based on the site where they are seeing them, for example, in the emergency room, for example, and then the service is paid under fee schedule. Now for ESRD, telehealth services are the benefits do include some of those telehealth services that we were discussing, particularly for those patients with a diagnosis of ESRD. Those related services are included in that monthly capitation payment where they have those 2 to 3 months that are required per month. And then ESRD-related services with 4 or more visits per month. You would be able to use telecommunication for those. In addition, you could use telecommunication for any medically necessary visits for medical management that are over and above those required ESRD-related services, with the caveat that at least 1 visit per month, again, must be face-to-face, hands-on with that patient. And in part, that is because it is required that they do examine that vascular access site as that patient is on dialysis. Documentation then for your providers would need to be very clear in where that service was rendered, so that your notes would very clearly identify a telehealth medicine visit versus a on-site, in-person, face-to-face meeting with the patient, so that that documentation could support that. And those services would be eligible for physicians or your non-physician practitioners. Telehealth benefits also cover, I mentioned this a little bit earlier, but in the hospital setting, your distant site professional service would be eligible for those subsequent hospital visits, and you are limited to 1 telehealth visit every 3 days. So it's not every subsequent visit that you would be performing that remotely. There would need to be on-site face-to-face sub-days as well. So Medicare guidelines are limited to 1 telehealth every 3 days. And these are the guidelines for hospital, inpatient, or nursing facility. There is on the hospital side also a frequency limitation that excludes our consulting providers. So the initial or follow-up consultations, there is a specific telehealth G code that would be reported for any consultants. And the consultation, of course, would be ordered by the treating physician or non-physician practitioner of record. Now, just a note on that, most of us on the phone who may be coding personnel or our providers that are on the call today, perhaps, we know that Medicare excluded those usual and customary consultation E&M codes, like the 994245, for example. Those codes were eliminated many years ago. This is a specific consulting G code just for telehealth. And some of those are specific to the emergency room. So you would want to take a look at those code descriptions before putting those into your fee schedule if necessary. Also for subsequent nursing facility visits, you are limited to 1 medically necessary telehealth visit every 30 days. And then the federally mandated periodic visits, as just a reminder on our nursing facility patients, Medicare does indicate when a professional staff must see the patient to examine them, whether they are symptomatic or not. And so those federally mandated periodic visits may not be furnished via telehealth. You would only be able to utilize that service for a medically necessary visit outside of those mandated visits. So if the patient had a new condition or new problem, a worsening problem, and the provider was called in to assess that specific problem, that's outside of those mandatory visits, but they just have to check in periodically on that patient. So those are guidelines you would also want to be very aware of. The acute stroke assessment was added last year. Medicare telehealth benefits do cover for the diagnosis, evaluation, or treatment of acute stroke. And there are no geographic limitations for the originating site. In other words, where is the patient when that assessment needs to be provided? So they might be in the emergency room, it might be a mobile unit in the office, and it would be urban or rural. There's no restrictions on where that patient is located, but just for this particular service. The professional staff who is rendering that service would report the appropriate telehealth code with modifier G0. And that modifier is appended to not only the distant site professional service, but also the originating site Q code to show that this interaction was an acute stroke assessment. So the originating site, again, HCPCS code Q3014 with modifier G0, And then your professional service for whoever is renting the distant site service, the appropriate HCPCS or CPT code, place of service 02, because you're most likely billing on the 1500 claim form, or the appropriate revenue code if you're billing under method 2, and then that would be appropriate for the assessment of acute stroke. For diabetic education, when the patients are receiving that formalized diabetic self-management training, there are telehealth visits that are benefits that will also be acceptable for that. This is why they've added those registered dietitians or nutrition specialists onto the list of eligible distant site providers. So in this circumstance, Medicare has said that under their benefits, group or individual diabetic education outside of any injection training, which of course would be required to be face-to-face, obviously, because that educator is training them on the use of injections if they're having insulin injections. All 10 hours of the initial training and 2 hours of the annual follow-up training may be provided by telecommunication. So you would have those codes G0108, that's that individual diabetic education of 30 minutes, and then G0109 is the group diabetic education of 2 or more per 30 minutes. I would also put a reminder in, especially for any of the RHCs on the call or any FQHCs on the call, that RHCs, particularly diabetic education, is not a covered service in the RHC setting. So that's something to keep in mind. For Medicare, again, they would not be able to provide that individual or group therapy for Medicare, regardless if over telehealth, because RHCs are not an eligible site for encounter or payment of diabetic education. Just wanted to toss that in as a reminder. I did pull just a few guidelines from Missouri Medicaid just to show you the difference or the similarity between the guidelines that we have. Also for your commercial and MCO plans, most of our commercial and MCO plans reimburse both the originating site services as well as distant site services, and the coding guidelines are very similar for commercial and MCO plans. Most of them are now recognizing that 02 modifier. They all recognize the Q code as that originating site indicator. And otherwise, most of your commercial and MCO plans, if they have any specific guidelines based on what distant site services can be provided, those are usually contained within their reimbursement and billing model manuals. I did want to pull just a few examples of state Medicaid plans. I know that the organizations on the phone today are across the country, but I did pull Missouri Medicaid, which of course has been addressing telehealth quite frequently over the last few years. The most recent communication from Missouri Medicaid was in 2018, just again indicating the billing for telehealth. They recognize both the distant site and the originating site services in a rural health clinic particularly, and this is for provider-based and independent RHCs in particular. You are to bill those telehealth services under the non-RHC provider number. In Missouri and in other states, our state Medicaid plans often will want your rural health clinic or RH or FQHC to enroll with with state Medicaid for a separate, what they call a non-RHC number. So you'll have your, for example, Medicare filing RHC or just your usual and customary clinic NPI group number that you have when you're filing to the payers, and that is usually used also for Medicaid. Then they often want you to also enroll for what they consider to be a non-RHC number, and that is often used for billing for rural health clinic technical services like lab or hospital services or other services that they want to have paid out of a fee schedule bucket instead of an encounter rate bucket. So telehealth is one service, both the originating site and the distant site. So for Missouri, they consider the professional service. If someone was calling into their RHC, they would also consider that to be paid under fee schedule. So they will still want that Q3014 if you have the patient there and are calling out. And then the appropriate CPT or HCPCS code with place of service 02 because you'll be filing on a 1500 claim form. And they do also want to see modifier GT on your professional services if someone is calling in to your RHC and have those services sent out, and then you would be paid under fee schedule. Now, one of the caveats that Missouri Medicaid put into place, and we have seen that with other Medicaid programs, and this is just kind of a rule of thumb that you do want to be conscious of, is that an originating site fee, where the patient is located, and the distance site fee, where the provider is located, can be billed by the same provider for the same date of service as long as the distance site is not located in the originating site facility. So that gets a little tricky. I mean, you want to make sure that, especially if you have a campus situation, that you're not having the patient over in the ER and you're calling over to your RHC. Medicaid would not think that that was appropriate because that provider could go over to the ED to see that patient. They wouldn't need to call over there. So you do want to be conscious of those types of scenarios, that you're not using that inter-facility to a great degree because some of the payers would not recognize one or the other of those service charges. Here's another example from Arkansas Medicaid. They do cover RHC encounters and ancillary services, which they have bundled telemedicine under an ancillary service. Arkansas Medicaid defines telemedicine as medical services, of course, performed as electronic transactions. That's really a universal definition. In order for a telemedicine encounter to be covered by Arkansas Medicaid, the practitioner and the patient must be able to see and hear each other, of course. They also include some other things like ultrasound and things like that. But just as a reminder, Arkansas Medicaid also covers both your distant and your originating sites. Here are some of these instructions under Arkansas Medicaid where they would use the 3014. Again, the Q3014 is your originating site. That is submitted on the appropriate claim form. They are looking, it is interesting here, since we know that the OIG identified that discrepancy where the professional service was sent through without a corresponding originating site. It says specifically in the guidelines under Arkansas Medicaid, and this is actually one of the manual instructions, is the code must be submitted for the same date of service as the professional code and must indicate the place of service where the member was at the time of the telemedicine encounter. So you know that they're also watching for that correlation. You are submitting the distant site services with the appropriate HCPCS code, and you'll note that Arkansas Medicaid would also want modifier GT. So really it's Medicare that decided to drop the GT modifier unless you're billing for method 2 in a critical access hospital, and they felt that that 02 place of service code sufficiently indicated that it was a telemedicine service. A number of these other payers, to include state Medicaid, still want to see the GT modifier on the professional service code in addition to place of service 02. So as a final thought, I wanted to just run through a billing scenario to give you kind of a visual or give you some thoughts on what your billing would look like. This is a 40-year-old patient who does present to the provider-based rural health clinic for an initial telecommunication evaluation of worsening depression and anxiety by a distant site, licensed clinical social worker located at a behavioral health specialty clinic in another town. So how would this be coded and billed? I'll give you a minute or two to think it over, and then we'll look at the billing scenarios. So again, this is a provider-based rural health clinic. Your patient is located there, so that is appropriate because the patient can be located at the rural health clinic and calling out. And this patient is specifically calling out to behavioral health for a visit with a social worker. I'll just give you a minute here to kind of get that thought in your head. All right, so we're really going to have a couple of things we want to consider. First of all is the originating site. Now this is a provider-based RHC, but if you remember some of our conversation, the rural health clinic, when they're billing for their originating site fee, They always report that on the clinic claim form. So even though this is a provider-based RHC, the hospital, the parent hospital, would not generate the claim form for this technical or facility service. This is kind of an exception to the rule on some of the things that we do want the provider-based parent hospital to drop. So you would use the UB04 claim form, the clinic UB04 claim form, under the clinic provider number, type of bill 711, because that's your clinic UB, revenue code 780, and HCPCS code 3014. That is what would go out on the clinic UB04. That's for what the patient is located in your site. Now the distance site provider, because you're going to want to have that correlated service, so the RHC will only drop that particular service. Now this is regardless if there is a nurse in the room with the patient, if there is another provider in the room with the patient. There is no professional billing in addition to that originating site charge. We have had that question quite frequently. Well, we have a nurse in there, or the doctor comes in and is communicating with the physician at the same time. There is no professional service that's billed when that provider is just in the room with the patient. That's all considered part of that Q code. The distance site provider would be billing out on a 1500 claim form. That social worker would use that clinic provider number on that claim form, and their individual NPI would be reported as rendering. They will report place of service 02, and in this scenario, they would be billing an initial assessment without the E&M service. So the 90791 is an eligible service code for them. Now, they would not be able to bill 90792 because for telehealth, a social worker or psychologist would not be able to report an initial diagnostic assessment without medical assessment. They would not be able, or with medical assessment. That is an ineligible code for those providers. But they would be able to report the 90791 for this particular scenario. So if we reverse the scenario, and we'll go back a slide, let's use the scenario of you have the RHC, but a non-Medicare patient. A non-Medicare patient is going to be assessed by one of your providers, and that patient is located elsewhere. So that patient may be actually located in another town. They're calling into the RHC because you have the social worker or psychologist on staff, and this is a non-Medicare patient, so it might be Medicaid. So the other site would bill out, usually on a 1500. If they're just in a clinic setting, they would bill the 1500 with a Q code and the place of service 02 to indicate they are housing the patient. And since they're calling into your RHC for the professional service, then you would drop the 1500 claim form to that non-Medicare payer. Under your clinic number, of course, place of service 02, the 90791, and then the social worker's individual MPI would be reported in that field 724 or electronic field to show that they were the rendering provider for that day. And that would be a non-Medicare scenario for a rural health clinic. So we have several resources to leave you with today, and there are multiple out there. Every payer has a lot of manual instructions. Sometimes they will have separate program transmittals or alerts that come out to you from the various payers about the guidelines for telehealth, but they're basically pretty universal, especially with the originating site code. That is pretty universal across the board. Use of modifier GT, place of service 02, those are things you want to watch for when you're looking at payer-specific information. We did leave you with the Rural Health Clinic Medicare fact sheet about their specific guidelines. Also, there was a change request that did come out in 2018 and 2019 for the removal of that GT modifier specific to Medicare telehealth services. I've also provided the link for the Medicare website for telehealth. Novitas also has a very good website and information that they've put together for telehealth that really covers all sites of service, so we would refer you to that site as well. And also any state Medicaid billing manuals that are specific to telehealth. We did not go through every state that's represented on the call today, but we would recommend that you reach out to your state Medicaid or make sure you pulled that instruction for your particular state, particularly in regard to any rural health clinics on the phone today or any FQHCs, to make sure that you do understand what their guidelines are. We have not run into any state plans that exclude billing for either the originating site or the distant site in a rural health clinic setting. That exclusion is specific to Medicare, but just from a coding perspective, it's helpful to know what your state requires. And then, of course, any commercial or MCO plan, make sure that you have copies of those manuals as well, so that you know what is acceptable for billing. And that concludes my formal statements. Shannon, I think I'll turn it back to you to see if we have any questions.
Thank you. I did see one come through from South Mississippi, I believe, and while we're going back to address that, I'm going to open the post polls if everybody wouldn't mind responding to those. And South Mississippi Regional Medical Center asks, when a facility credentials a provider with CMS, is the address where the provider is physically located listed on the 855 and also on the 1500?
Yes. Your 855 or your enrollment form should always reflect where that provider is going to be primarily practicing. So there may be varied sites of service that you'll have included in that 855 form. It may be clinic, it may be hospital, they may be going out to other hospitals or other nursing facilities, but the 855 forms really serve to show not only are we enrolling this physician or non-physician practitioner, but these are the sites of service where you would expect to see claims coming from as far as the site of service for professional services. So yes, those would both reflect. Hopefully that answers the question. Let me know if it does not.
Thank you. And then Gail chatted in a question as well, wondering if she would be able to email you directly, Marla, with a specific question about the content.
Oh, yes, absolutely. Yeah. Anyone on the phone is more than welcome to email me if there's separate questions. Be happy to address those. Oh, and I do see that our training did assist. I see some corrected answers, especially for the RHC. 100% reversal. I've noticed that's very good. Yes, that's one thing that we do need to remember on the RHC side, and that is posed a big problem for some of our clients that we work with, in that that's really what they want to do is provide those specialty services, particularly for behavioral health. And for Medicare, at this point in time, we're not able to. So cross our fingers that the Congress does move that legislation along. There are probably 6 or 7 different elements of that act, but the telehealth is really the one everybody's watching to make sure that that passes. So we'll watch that very carefully.
Well, thank you so much for your time today. We really appreciate you providing this telehealth overview. I think it was really great, and clearly the post polls show that our hospitals really gained a lot of knowledge through this. Just a couple of reminders as we're approaching the end of our time together. The next Revenue Cycle Improvement webinar will be next Thursday at 9 a.m. Central Time. The topic is in hydration, infusion, charge capture, and medical necessity, so please feel free to